Thank you very much. I'm Dr. Ishaq Abu-Arafeh. I'm a consultant in pediatrics and pediatric neurology, and I work in Glasgow in the United Kingdom. I've been involved in the treatment and research for headache in children for over the past 30 years. And I'm very pleased to be part of the International Headache Society's Child and Adolescent Subcommittee, which I chaired for 8 years between 2013 to 2021.
Dr. Ishaq, can you share with us some good news about management of headache in children?
Yeah, headache in children has always been a problem. It has been a problem for many reasons. One of them is very little research has been done, especially in the treatment and in the clinical trials. However, the good news are that we are now involved in several clinical trials, especially for the management of children with CGRP monoclonal antibodies. There are 3 compounds which has been trialed in the children now, and we are now seeing the results of the trials coming up gradually. It is promising, and it is opening a new door for a treatment of children with migraine in particular, and hopefully will reflect in the future for a better management of headache and migraine in children. As you know, lots of medications for the prevention of migraine in children have been controversial. Some of them are not very well tested, although in the IHS we have set quite a lot of guidelines on how to carry out clinical trials in the treatment of migraine in children, but there are lots of barriers in the way of achieving that. The other good news is we are now seeing a lot of well-conducted trials which follow the IHS guidelines. But the distinction between acute or episodic migraine and chronic migraine is an issue. And children don't usually follow the book. And quite often they fluctuate between episodic migraine and chronic migraine, and makes allocation of these children in which arm of the trial a bit challenging.
Professor Ishaq, now we are in the IHC 2025 in Sao Paulo, Brazil. Can you share with us some insights from the conference?
Yeah, I think my focus is on the treatment of children. And unfortunately, usually little coverage for pediatric headache is achieved in many conferences, including the IHS. However, I'm pleased that there are at least 2 sessions in this conference which focus on children and treatment. And also, I can share with you that I have been part of a group of 8 experts in pediatric headaches, working together to put guidelines for the management of migraine, whether acute or prevention. And we are in an advanced stage in collecting the data, in searching the literature, and assessing the evidence. And hopefully, within the coming 6 months, we will have a publication to show the up-to-date advice and guidance.
Professor Ishaq, how do you see the differences between children and adults regarding the migraine criteria and characteristics?
Yeah, I think this has been discussed on many occasions, and as you are rightly so to highlight this, because there are lots of clinical differences in how the children present with migraine. For instance, the duration of attacks tend to be shorter in children, but not all the time. Probably the younger the child, probably the shorter the attacks, but when you reach teenage, probably the child will have similar to adult presentation of migraine. The unilateral headache is less common in children under the age of 10 or 12. It's more likely a child to present with either frontal or bilateral headache. The other symptoms such as nausea and vomiting is quite more exaggerated in younger children than in adults. And because of that, it comes early and make oral treatment with for acute attacks another challenge. And quite often you deduce the symptoms by behavior of the child. So the child might not say to you that they have photophobia or phonophobia, but the way they behave, they isolate themselves, they cover their eyes, they withdraw from conversation might be an indication of photophobia, phonophobia. Refusal to accept meals might indication that an element of nausea, and reluctant to participate in activities, whether games or play or sports, or even fun at home is an indication of intolerance to physical activities. So an expert and a skillful clinician can deduce all these symptoms from the child's behavior and do not rely that the child articulate that, because children, even and sometimes many adult people, they have difficulties in describing pain because it's an abstract idea, whether it's throbbing or is it pounding or whether it is dull or it is aching. This is an abstract thinking, and you don't expect that child to come straight away and say to you what these characteristics are, but you have probably allow that child to use their own words, and maybe you translate that into scientific assessment as you assess that child.
Thank you, Dr. Ishaq, for your time.
Thank you very much.